Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. The new clinical guidelines for juvenile and adult axial spondyloarthritis are intended to help clinicians navigate the difficult, often uncertain decisions that arise in everyday practice. The patient in front of us may have inflammatory back pain but an equivocal MRI. They may improve with an NSAID, only to relapse every time they stop it. They may also have psoriasis, uveitis, or inflammatory bowel disease that changes which treatment may make the most sense for that particular patient. The patient may have failed several therapies, or they may be a teenager whose most important goal is not a disease activity score, but simply to being able to keep playing football. The guidelines also give us a rare opportunity to compare how we approach the same disease across the lifespan. For the first time, juvenile axial spondyloarthritis has its own dedicated guideline. And in adults, radiographic and non-radiographic axial spondyloarthritis are now approached as part of a unified disease spectrum. To discuss what changed, why it changed, and what these recommendations mean for our patients, I'm joined by two of the primary authors. Dr. Liron Caplan led the adult axial spondyloarthritis guideline, and Dr. Matthew Stoll, who led the pediatric guideline. We discuss when MRI is necessary, whether NSAIDs should still be considered first-line therapy, and how to choose among TNF inhibitors, IL-17 inhibitors, and JAK inhibitors. What to do after the first biologic fails. Why methotrexate generally has little role to play in axial disease. And how to think about physical activity, contact sports, manual labor, tapering, dose escalation, and even dual-targeted therapy. We also explore why these guidelines do not endorse a rigid treat-to-target strategy, and how the guideline writers make recommendations when there's little evidence that doesn't provide a clear answer. Dr. Matthew Stoll is a pediatric rheumatologist at the University of Alabama at Birmingham. His research focuses on pediatric spondyloarthritis, including its relationship with inflammatory bowel disease and the intestinal microbiome. Dr. Liron Caplan is an associate professor of medicine at the University of Colorado School of Medicine and a rheumatologist and health services researcher specializing in spondyloarthritis. His research examines how treatment selection, adherence, and healthcare delivery affect patient outcomes. Enjoy. Matt and Liron, welcome to the show.
Thank you.
Thank you.
You know, it's an incredible pleasure to have both of you to talk about the new axial spondyloarthritis guidelines for both adults and the guidelines for children. This is going to be a really interesting discussion where we sort of compare and contrast, how we think about caring for adults versus how we think about caring for children with the same disease. Liron, I wanted to start with you. I think previous guidelines for axial spondyloarthritis made a big deal about sorting out whether you had radiographic axSpA or non-radiographic axSpA. For the first time this year, the guidelines sort of bunched those two classes into just axSpA. Can you talk a little bit about how you made that decision to bunch these two, what were previously considered two versions of the same disease, now just into one?
Well, I think with the previous iteration of the guidelines, there was a concern that the non-radiographic and radiographic manifestations of the disease might behave differently. And as we've had more experience and there's been more data that have been produced, they've reassured us that these are really similar enough that there don't have to be specific guidelines for each manifestation. And so I think it's just a recognition of that state of the art.
Great. The other thing that is very different between these guidelines and previous, and this is for you, Matt, is that previously, the JIA guidelines were these like huge documents that contained how you treat oligoarthritis and polyarthritis and like TMJ disease and systemic JIA. And this is the first time that like juvenile axSpA has its own separate guidelines. Why did you think this was necessary?
So that you are correct. The 2019 guidelines included sacroiliitis in childhood. And we found as we worked our way through it that we had very little data to go on. So at that time, there had not been any studies of IL-17 inhibition or JAK inhibition in children with sacroiliitis. So we were neutral on those topics. On the other hand, the adults have an abundance of data for many of the questions that we asked. And by working with them, we were able to gain from their expertise and extrapolate from their data. So one example among many is physical therapy. Is physical therapy effective in the treatment of patients with axial spondyloarthritis? We looked at that in 2019 and said we can consider physical therapy if the patient is at risk of loss of function because there are no studies in children. When we work with the adult rheumatologists and are able to extrapolate from their information, then we are able to provide a recommendation in favor. Likewise, with IL-17 inhibition, there is a study in children with spondyloarthritis as a whole without a dedicated focus to axSpA. With JAK inhibition, there are studies now in children with JIA as a whole without any focus at all on axial involvement. So if this were a standalone guidelines without extrapolation, we would not be able to provide very strong recommendations in favor of these therapies, while by working with the adult rheumatologists on this and extrapolating from their data, we were able to provide a strong recommendation for both TNF inhibition and IL-17 inhibition, as well as a conditional recommendation for JAK inhibition.
Matt, given that you work sort of closely with the adults and you're borrowing, some of the adult data, were there ever discussions about having one document that covers both children and adults with axSpA rather than dividing it into two?
Yeah, so that question did come up primarily when it was under review by the American College of Rheumatology. And there are some differences in the data, some differences in general approach, and as well differences in safety concerns where we felt it is worthwhile to keep these two documents separate.
Amazing. So let's talk a little bit about, one of the toughest thing is diagnosing these diseases, right? So you have a lot of patients complaining of back pain or morning stiffness. Liron, how does sort of the adult guidelines go about making the diagnosis of axSpA, especially as it relates to imaging?
Thank you for that question. The diagnosis is based, of course, on a thorough physical exam and a history. When it comes to imaging in particular, there's still an acknowledgement that X-ray may play a role, especially in resource-limited societies or communities. And there's also an acknowledgement that MRI is a crucial imaging modality. And so there's heavy reliance on MRI with a host of recommendations around the appropriate ordering of MRI, the appropriate evaluation of MRI. That is an area of considerable emphasis in these guidelines compared to previous versions.
Great. So it sounds like, at least in the adult world, if you have a patient with signs and symptoms of axSpA and you have a confirmatory X-ray that shows ankylosis or erosions at the sacroiliac joint, the diagnosis is made and you can sort of proceed with treatment. And I guess, similar to prior, if the X-rays are non-diagnostic, that's when you would maybe rely more closely on the MRI.
Exactly. And then, of course, there needs to be appropriate expertise in whoever is reading these MRIs. And that is, again, an area of emphasis in these guidelines, really an acknowledgement that we do need to increase the expertise in the community in becoming familiar with these imaging modalities and being able to use them and apply them to patients.
Great. Matt, talk a little bit about sort of the same question. How do you diagnose juvenile axSpA in patients presenting to your clinic based on these recommendations?
So in general, you're going to need an MRI. And a large part of the difference is that children with enthesitis-related arthritis tend to have a much shorter diagnostic delay compared to adults. In part, that is because if you are 14, 15, and you get your first symptom and you wait 10 years, you're going to see an adult rheumatologist who is not going to look at the pediatric guidelines and say, well, he was 15 when this started. We're going to look at the adult guidelines. So if you haven't had disease for very long, say 1 year, the experience has been, the literature shows that the x-rays tend not to be very helpful. Even if a radiologist thinks there is some sclerosis, then that ends up being an overcall or non-specific. So what we've learned in our field is that you need the MRI to establish the diagnosis.
hmm Do you typically still get radiographs? Like when, just practically speaking, you see patients, you wonder about axSpA. Do you get radiographs while you order the MRI, or just jump straight through the MRI? I know in the past, some insurance companies have said, well, you haven't had radiographs. Why are you jumping to MRIs?
So yes, most insurance companies are going to require an x-ray in order to approve the MRI. I'm hoping that once these guidelines are published, that at least for the evaluation of axial spondyloarthritis, we'll be able to bypass the x-ray and move straight to MRI.
Great. So once you've made the diagnosis, how do the guidelines talk about using NSAIDs as quote unquote first line therapy? Liron, how do the adult guidelines approach the use of NSAIDs for patients with newly diagnosed axSpA?
The previous iterations of the guidelines advocated for use of NSAIDs and didn't really make any other conditions or circumstances that would mitigate that recommendation. In the current guidelines, certainly most patients are going to require NSAIDs as first-line therapy. However, in those that have markers of poor prognosis and are at risk for progression, particularly rapid or severe progression, namely those who at the time of diagnosis have elevated CRP or have the presence of syndesmophytes, in those folks, the guidelines make a conditional recommendation to proceed to biologics therapy, in this case, TNF inhibitors or IL-17 inhibitors. And that's a distinction from the previous guidelines.
And it sounds like there may be a preference of a specific NSAID over other NSAIDs.
Well, there are better data around COX-2 inhibitors, in particular for Celebrex. But this, of course, requires tailoring the therapy to the specific circumstances of the patient. And there are limited data around that issue. So it's very much a conditional recommendation.
Very good. Matt, how does that compare to the juvenile axSpA guidelines?
So in broad strokes, these are very similar. We as well recommend NSAIDs as first-line therapy, except for those at risk of poor functional outcomes. Some of the differences, one, a very minor difference, is that the adult guidelines recommend 1 month of NSAIDs with 2 different NSAIDs over 2 weeks each, whereas we stick with just one NSAID over 4 weeks. Our definition of those at risk of poor outcomes is a little bit different insofar as pediatric data shows that hip involvement is a risk factor for severe and poor functional loss. And so that's one of the indicators, along with arrestive change on MRI and elevated inflammatory markers. So patients with any of those can progress directly to biologic therapy based upon our guidelines. An additional area of interest is what happens to a patient who goes on NSAIDs as first-line therapy, feels great while they're on NSAIDs for more than a month, but if they try to stop the NSAIDs, then the symptoms come back. And Liron, correct me if I am incorrect, but my understanding is that with the adult guidelines, such a patient will stay on NSAIDs possibly for months or a year, so long as they are doing well. For the pediatric guidelines, what we discuss is that after 1 month, if they still have an NSAID requirement, that's when you start the conversation with the family Do you want to stay on the NSAIDs indefinitely? Or if you need to be on this for a long time, do you want to think about going on a biologic?
Well, for the adults, it is predicated on whether they have inactive or active disease. In the event of inactive disease, then it's reasonable to taper the NSAIDs to off. But in those who have ongoing symptoms, i.e., active disease, we do make a recommendation to continue the NSAIDs.
Great. And when thinking about patients that fail the trials of methotrexate or that are at high risk, as you mentioned, then we have sort of like a plethora of options to start patients on treatment. How should we go about thinking, which medication may be best for a particular patient?
Well, let me jump in first and say that neither set of guidelines requires a patient to have failed a trial of a conventional synthetic DMARD, such as methotrexate or sulfasalazine. Both of them recommend against those unless there is some extra musculoskeletal manifestation for which those are effective.
So I guess, Matt, you're saying patients should not waste time on methotrexate and sulfasalazine. They should just go on biologics. Liron, once you have a patient that either you think has failed a trial of methotrexate or at high risk, how do you choose among the various different options for treatment, including biologics, targeted synthetic DMARDs? And does the fact that they have psoriasis or uveitis, how does that play into your selection of medications?
Well, just to be clear, patients for axial disease, at least, we're not recommending the use of conventional synthetic DMARDs. But the scenario in the way that you describe it, where someone is on those medications, presumably it would be because of the initial presence, let's say, of uveitis or psoriasis, and then the discovery of axial disease. And in that circumstance, we're going to make a recommendation first for TNF and TNF inhibitors and IL-17 inhibitors first, with targeted synthetic DMARDs, specifically JAK inhibitors, as a subsequent therapy to consider. And the catering and tailoring of therapies, as you alluded to, really does depend on the co-occurrence of comorbidities or disease manifestations. So in folks with, for example, psoriasis, particularly severe psoriasis, one may consider perhaps IL-17. But for the purpose of these guidelines, TNF inhibitors and IL-17s, for the general patient, they're considered equivalent. Of course, if a patient's axial spondyloarthritis is complicated by inflammatory bowel disease, in that circumstance, you're going to elect for TNF inhibitor over an IL-17 inhibitor.
Yeah. And Matt, correct me if I'm wrong. I think previously the guidelines for axSpA, I think, suggested TNF inhibitors, as the sort of the first biologic. In these guidelines, both in adults and in children, TNF and IL-17 are sort of at the same level. Can you talk a little bit about that decision and why has that changed from previous guidelines?
Well, in pediatrics, it changed because one, we now have a study showing that secukinumab is effective in the management of children with enthesitis-related arthritis. And there were some axial outcomes that were explored that showed some benefit in there as well. We're also able to benefit from extrapolation from the adult experience where TNF inhibitors and IL-17 inhibitors are both highly effective. So to emphasize what Liron spoke to, in a patient with a history of uveitis, we would lean towards TNF inhibition. In a patient with severe psoriasis, we might lean towards IL-17 inhibition. Likewise, if they have or there's concern for inflammatory bowel disease, we might lean towards TNF inhibition. Other factors may be family driven. Some families, when we discuss the black box warning, raising concerns about the potential malignancy risk with TNF inhibitors, even though the data are very reassuring, especially in children and young adults, some families are very concerned about this. And so for them, we can say, well, IL-17 inhibition is considered equal to TNF inhibition in these guidelines. So we can move forward to IL-17 inhibition. Or even something as basic as the frequency of injections may drive the decision making for some families.
Hmm. And Liron, how do the adult guidelines talk about failure of of the first biologic? Let's say you started somebody on a TNF inhibitor, and whether it doesn't work or maybe they do well for 6 months and then it stops working. What do the recommendations say about trying a second TNF agent versus switching a different class of drug?
So the previous guidelines in 2019 predicated your decision in the event of a need to change medication on whether the patient responded to the TNF or whether there was a secondary failure, meaning initial response but loss of response after 6 months. And under those guidelines, if the patient had a response that they lost, it was recommended to try another TNF, whereas primary failure was an indication to immediately jump classes. In this guideline for adults, we liberalized the decision making, really allowing folks to either switch class or remain within class, regardless of the initial response. And that was to acknowledge patient preference and also to reduce barriers around insurance mandated selection of therapies.
Yeah, exactly. That's another big thing. You may want to switch your patient to a different class of drugs, but your insurance company may mandate that they fail, 2 or 3 different TNF inhibitors, for instance, before switching to something else. I think another great thing about these guidelines is that you don't only focus on the medical management of these diseases, but both guidelines also discuss very well other stuff patients should be doing to better manage their condition. Matt, can you talk a little bit about some of those non-medication related treatment approaches for juvenile axSpA?
Much of this is extrapolated from data in adults with axial spondyloarthritis. So, for example, physical therapy. There are no studies involving children with axial spondyloarthritis. So, we extrapolate from the adult rheumatology literature, where it's quite clear that physical therapy is beneficial, that staying active is beneficial. So, we provide conditional recommendations for these as well. The adult rheumatologists provide a strong recommendation. Ours is conditional because we understand that many of our children are very active to begin with. Either they're playing sports, they're doing other activities, that physical therapy, because there's only a limited number of hours in a day, we don't want our children to discontinue an activity that they already are engaged in, are enjoying, is meaningful to them, so that they can go to their therapist 3 times a week to try to replicate some of these activities. And this is also conditional because we don't have the data in children.
Hmm. And Liron, was struck reading about the role of heavy, intense physical labor and how what the recommendations are related to that in axSpA. Can you talk a little bit about why those may be important?
Well, thanks for asking that question. That was a area of some controversy during the voting panel, and the competing priorities in that discussion were the acknowledgement that we have data showing an association between the types of labor that involve repetitive stress and severe outcomes, more untoward outcomes. But that was counterbalanced by a concern that certain patients are constrained by what occupations they can pursue. And so the recommendation was not one against pursuing certain occupations, but rather an encouragement that the provider have a discussion with the patient about that association, and that together, whatever recommendations or suggestions come out of that be arrived at through shared decision making and an informed patient.
Matt, how is that viewed in the sort of the pediatric world, especially when kids are participating in competitive sports? They play soccer and football, and they may do gymnastics or whatever. What are the guidelines suggest about the recommendations of sports and especially contact sports in children?
That is a great question. A lot of this discussion started in 2013 when this mouse model of spondyloarthritis was introduced, where you raise them by the hind tail and suspend them by the hind tail disease is attenuated in these animals. And so the question that we've asked since then is, what about our children? Now, we know that we're not going to tell them go to bed, to have bed rest as treatment. We know that physical therapy is very helpful, especially in adults. But what about contact sports? What about football? And so we had that conversation. And what we decided to phrase it as, instead of saying, don't do this, we are instead counseling about theoretical risks of disease progression, especially in someone who has active spondyloarthritis. So we're not telling them not to play sports. We're not telling them not to play tackle football, but instead there is this possibility that, especially if you have active disease, that things may worsen. Certainly if you have cervical spine involvement and severe disease, then maybe this is not a very good idea for you. But that circumstance is rare in children. But instead, ultimately, we want our patients to live their lives to their fullest, and we don't want them to be constrained by their diagnosis.
Yeah. Interesting. It's always a fine line. You may say, it's like, we want you to exercise, but don't exercise too much, or, avoid playing sports. That's tough, especially for a child who may enjoy competitive sports to think about, and that, they may prioritize being active today.
And I want them to. So if I have a patient who is interested in any number of sports or any number of activities from football to baseball to chess, and they're all equally important to them, I might try to steer them towards something that has less risk of trauma. But if I have someone, and I live in Alabama, people love their football here, and I have someone whose heart is playing football, and this is the most important thing to them, I'm not going to tell them, and in fact, the parents might listen to me. So I'm not going to tell them, don't play football, this is where your heart is. But instead, I'll tell them, these are possible risks, and just do what you take that information to heart.
I think it's also worth noting that these guidelines, in terms of non-pharmacologic recommendations, have a rather dramatic expansion in their scope compared to the prior guidelines, with some recommendations, conditional recommendations, for things such as acupuncture and massage therapy, yoga, tai chi, but with the heaviest emphasis overall on physical therapy and its various iterations.
Yeah, I mean, I think that's always good. Like, you're telling patients to be active, right? It's important, but maybe avoiding the extremes of like contact sports or very heavy manual labor that may actually worsen the disease. I guess, especially Matt, like you said, maybe if the disease is active, if it's inactive, maybe it's safer. I don't know. Something to think about. Liron, treat to target has been sort of like the mainstay of a lot of the diseases that we take care of. We have treat to target for RA, and we're targeting a certain serum uric acid in gout. But unlike other diseases, the new guidelines do not recommend a treat to target approach for the treatment of axial spondyloarthritis. How did the group come to that decision?
I think it's important to be clear on what we're talking about when we discuss treat to target within the setting of axial spondyloarthritis, because the voting committee and the task force for the guidelines did want to clarify that we're not talking about not listening to patients. Quite the contrary. We want that to be a very active and dynamic discussion that's two-way. But in the setting of axial spondyloarthritis, treat to target means regular assessments using a structured approach and mandated acceleration or a deceleration of therapy based on those objective measures. So it's sort of this very rigorous or protocol-driven approach to care. And the fact of the matter is that this has been studied now in two very rigorously done randomized controlled trials, one which has been published in a full form and the other one presented in abstracts, and both failed to reach their primary endpoint, although there were some secondary endpoints that were achieved. But still, in acknowledgement of that, we advocate for a more informal approach that involves the careful solicitation of symptoms by the provider and engagement of the patient, again, in shared decision making, but not sort of this mandated algorithmic approach to care, particularly given where the data are.
Great. Matt, how should we think about patients who are doing well and they're on a biologic or a targeted synthetic DMARD and they've reached inactive disease? How do the guidelines suggest that should we think about stopping their medications, tapering their medications? What's your practical approach that you do in clinic?
Tapering the biologic or the targeted synthetic DMARD is something we can consider, but only if this is something the family and the patient wants to do. So this should not be mandated by insurance, but rather if they have been in inactive disease for a period of time and the family is interested in doing this, then you can, for example, space the dose of the biologic.
Yeah. And Liron, I was interested to read in the adult world for patients that aren't doing well on regular dosing biologics, you recommend in some cases going above FDA, quote unquote, FDA approved doses to treat axSpA in patients that may not be having a full response to the initial dosing.
Yeah, well, the fact remains that in axial SPA, we have a limited armamentarium for addressing this condition. And so we have to be very careful and really use every medication to the fullest before extinguishing it as a therapeutic option. And in that light, and particularly given that there are data in other related conditions at higher doses demonstrating a reasonable balance between benefit and risk. In light of those data, it made sense to the voting panel to allow those same doses, which may be above the approved doses by the FDA for axial spondyloarthritis, to treat axial spondyloarthritis when the approved dose is inadequate. And so, yeah, there are definitely these circumstances where the committee felt a conditional recommendation was warranted.
Yeah. And another thing that was mentioned in the adult guidelines were this idea of dual therapy, right? Which I think for the first time I see written down in guidelines that patients that are not responding to a biologic or a targeted synthetic DMARD, thinking about the combination of two different biologics or a biologic plus a targeted synthetic DMARD. Can you talk a little bit about some of the evidence for that or why the committee felt that that should be included in these guidelines?
Well, just to be clear, that scenario is one that you'd arrive at only after you're thoroughly convinced that the patient does, in fact, have the correct diagnosis and you've formally reconsidered that possibility that the diagnosis may be in question and that the symptoms that are driving the acceleration of therapy are due to the axial spondyloarthritis. And in that scenario, there is a conditional recommendation for considering dual therapy, particularly when the patient has multiple manifestations of disease, such as axial SPA and IBD. And in that circumstance, there's a fairly soft observational data. There's some slightly more rigorous data that comes to us through the IBD literature, but we didn't make that recommendation based on the strength of the data and more so the circumstance that warrants a change in therapy with very few other therapeutic options. And so it's one that we do have a conditional recommendation for, but only under this fairly narrow circumstance.
Yeah, Matt, how do you think about sort of this dual therapy in children with active SPA that aren't being able to be controlled on a single agent?
We think of this very similarly. So in practice, this often will be individuals who have distinct disease manifestations such as inflammatory bowel disease and axial spondyloarthritis, where of course you want to make sure that the symptoms in both cases are due to active inflammation and not, for example, irritable bowel syndrome and nociplastic pain for as a cause of the back pain. Once you've assured yourself that the symptoms are inflammatory, then certainly you can try dose escalation of a biologic. In practice, often we have a situation where, for example, the only pathway, the only mechanism that is treating the inflammatory bowel disease, let's say, is IL-23 inhibition. The only mechanism that is treating the axial spondyloarthritis is TNF inhibition. And so you work with the gastroenterologist, discuss with the family the theoretical risks of infections, and you can treat them with both.
Great. I couldn't help but be in awe of both of these guidelines because they are so extensive, not only in the number of pages, but like all of the different questions that the group answered. Liron, can you talk a little bit about what the process was like and your reflections after completing this awesome document?
Thanks. Before I go there, I just wanted to make one other comment about the last point. It's worth noticing that for the adults, you're not going to consider the dual therapy before you've tried in those that are eligible for it, of course, the 3 approved medication classes. That's not a specific recommendation, but merely an extrapolation from the fact that the 3rd medication class recommendation, that is typically a JAK inhibitors, is going to be a strong recommendation, whereas the use of doses above the FDA-approved dose or the use of dual biologic and targeted synthetic DMARDs is a conditional. But I'm really glad that you asked that question about how we came to the scope. We took the charge by the ACR to consider future scenarios and the full clinical world of possible scenarios seriously. And with that, we were very systematic in how we identified all the domains that we wanted to address and the clinical scenarios, not shying away from areas where there is little to no data, because in the real world, clinicians don't have the option of suspending their decisions, and certainly patients are in the same boat. You're making decisions in the absence of data. And so we really wanted to honor those circumstances where the clinician and the patient were looking to the experts to provide guidance. And so we provided that guidance, acknowledging that in those circumstances where there are little to no data, a decision still needs to be made. And so we offered that.
Great. Matt, can you talk about some of the challenges of writing these guidelines? Were there any controversial topics, or what was the most challenging part of putting this document together?
The most challenging part was getting feedback from some 40 co-authors who had different opinions. One of the most challenging topics was what we had alluded to earlier in the podcast, which is, what do you do if you have been on NSAIDs for 1 month, you're feeling better, but if you try to stop the NSAIDs, the disease comes back? And there's a whole range of opinions from some panel members who don't think we should be using NSAIDs at all, or at least NSAIDs should only be adjunctive, but all patients should be treated with biologic from the beginning, regardless of whether or not NSAIDs are helpful, to others who would adopt the adult approach, where if they respond well to NSAIDs, they may remain on NSAIDs indefinitely, so long as they are tolerating them well as well. So trying to take all the disparate opinions and have one document that's going to be acceptable to all the co-authors, all 3 organizations that are sponsoring this work, that was a real challenge.
Yeah. How long have you guys been working on this document?
Well, the document actually, that moved very quickly thanks to the expertise at the ACR and the fact that we had over 60 folks working on both guidelines together. But it's been years. It's probably been a 3, really, the
Wow.
active part has been 3 years. But we're hopefully now in a position, having laid out all of these clinical scenarios, to conduct the searches quickly and produce updates to the guidelines with a much more rapid and efficient cycle.
Yeah, how are you guys thinking about updating these guidelines now with artificial intelligence? Like, are you thinking that, in 3 years you'll revisit each of these questions, or is there a chance, as new data come along, for this to be sort of like a living document that gets updated sort of automatically as evidence pops up?
We actually did use some AI as a second reviewer at the abstract stage. So there are some nascent efforts there to incorporate AI in guideline development, and it is occurring at multiple stages. We didn't have any steps that were entirely driven by automation, but we are dipping our toe into that pool. In terms of the incorporation of new recommendations, even through the process of producing these guidelines, we identified at least maybe 15 or 20 scenarios that already need some refinement, some minor tweaks to language, and in other cases, new scenarios, new PICO questions entirely. But we do anticipate having a more streamlined process and being able to iterate much faster. And so certainly in less than 3 years, and hopefully as quick as maybe once a year.
Matt, any concluding thoughts before we finish this podcast?
I'm really thrilled with the work that we made on this. I think these are going to be beneficial in terms of providing guidance to pediatric rheumatologists as well as adult rheumatologists who take care of children as far as what steps to take to evaluate children with suspected axial spondyloarthritis and how to go about treating the axial involvement as well as the associated disease manifestations. I believe this is going to be a huge step forward and will provide a lot of benefit to the field.
Yeah. Liron, last thoughts?
I just wanted to acknowledge all of the collaborators. This was just a massive effort with some incredibly talented folks. And I'm in awe of my colleagues, and it's been a joy to work with them and benefit from their concern and their expertise.
Yeah. And I think, as a clinician that treats both adults and children, this is hugely beneficial to us so that when I'm taking care of patients in the clinic with axSpA, whether a child or an adult, I can refer to these guidelines and think about, what's making sure that I have sort of the best evidence-based decisions or suggestions. And certainly, as you mentioned, Liron, like we may not have all the answers, but at least, you guys have thought about, all of these scenarios and provided sort of what the best evidence shows, even though that evidence may not be so robust. So certainly we all benefit from this. Matt and Liron, I really thank you for this awesome project that you guys undertook and for plowing through it for the last 3 or so years. And I look forward to discussing the updates to the 2026 guidelines sometime in the future.
Thank you so much for having us. It's good to see you again, John.
One of the most important lessons from this conversation is that guidelines are not simply lists of preferred medications. At their best, they are maps for navigating uncertainty. These new recommendations give clinicians greater flexibility to move earlier to biologic therapy in patients with risk for poor outcomes, to choose either TNF or IL-17 inhibition based on the whole patient, to switch either within or between drug classes, and perhaps in carefully selected refractory cases, to consider dose escalation or even combination therapy. But they also return us to the same principle that treatment decisions cannot be separated from the patient's priorities. For one patient, that may mean minimizing injections. For another, it's controlling their uveitis or their inflammatory bowel disease. For a child, it may mean continuing to participate in the sport that gives their life meaning. And for every patient, it means distinguishing active inflammation from the many other reasons someone with spondyloarthritis may still experience pain. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, on Apple Podcasts, Spotify, and on your favorite podcast app. Until next time, keep your guidelines close, but your clinical judgment closer. And of course, stay healthy.